I invite to the stage Nicola, who will talk about the amazing campaign Gloves Off, which is still one of my favorite campaigns ever. Oh, and you can use that mic.
Is that okay? Yeah. That's quite a big shout out to say your favourite topic ever. I'm Nicola Wilson. I'm technically a paediatric nurse is my background. I'm also a qualified teacher, so my day job is nothing to do with sustainability, really. It's teaching nursing at Great Ormond Street Hospital, which is a children's hospital in London. And I'm here to talk to you about a project that, to me, feels like a lifetime ago, that we started back in 2017, and has kind of escalated across many different hospitals since then. Not just me in the picture of the people that led it, and I think that's really, really key. I'm a massive, sort of passionate person about bottom-up change, and everything we've heard about today has been a lot of sort of top-down change, policy, and sort of the much bigger picture. But for me, how do we make that practical in the reality of the healthcare setting, and how do we do that bottom-up change? And I couldn't have done it without my two colleagues. So I've told you that I'm a nurse educator, as is Amy Leonard here, one of my peers. And in the middle here was our nurse consultant, lead for infection control. And I think that was one of the key things about doing a project, is who you have as your allies when you lead something like that, and trying not to just do it by yourself. I've since learned a new term a few weeks ago where a lot of people have issues implementing sustainability projects because of their infection control team. And it's even now known as yellow washing, where their infection control teams say, oh, we can't do this. And so to have Helen on board right from the start really, really helped us. So why on earth did we even look at this? So in 2017, there were a few key things that came together that meant that I had no option but to do this project. The first one was that we changed the way that the hospital did our hand hygiene audits. I had gotten a little bit fed up of sitting in matrons' meetings with people saying that their hand hygiene was 100%. Because I'm a pretty good nurse. I teach nursing, but definitely my hand hygiene isn't 100%. And what we realised that actually our data collection wasn't that good. And so we needed to improve the data collection. And as we did this and we changed the way we collected it, we moved people from not just collecting quantitative data, but collecting qualitative data. So if there's a moment where you're not performing hand hygiene, why is that? What are you doing in that moment that's distracted you from doing that skill? And we changed our audits from just simply data collection, where we would send teams out across the hospital every month, and they would go and collect this data and then do nothing with it, to actually understanding what audit is and saying, okay, let's collect this data, let's collect quantitative and qualitative data, and then let's just do it once a quarter so that you can make a change about it. So we really empowered staff and taught them actually what audit is. And when we first sent them out to do these audits and listened to the results, the true qualitative data, the main reason that people weren't washing their hands is because they were still wearing their gloves at the time that they should have washed their hands. Another thing that we saw, and I think completely iterated first thing this morning, is if you have been doing 12-hour shifts of IV antibiotics, drugs after drugs, and you've washed your hands, you've dried them, and then put them in a pair of gloves, you've got damp hands in gloves, and they just break down. So at the end of a 12-hour shift, you've got nurses with really red, raw hands as a result of just giving their normal care. Helen had just come back from our RCN, so that's one of our unions, to help update our national guidance as well. And I also ran a study day for our nurses across the trust to make sure that we were administering our IV antibiotics or IV drugs in general in the same way across the trust. Because we have something like 57 specialties, probably as many as a Heinz baked beans or something. And we needed to make sure that actually we were still obtaining best practice across the trust. And when I ran this day to sort of say, okay, the people that are teaching it, are you teaching it in the same way and to this best practice? Helen had come back, having just updated the national guidance, and really questioned, why are you wearing gloves for that? And we all went, because infection control would tell us to. And she was like, well, I'm not telling you to. So really, all these things linked together made us think, okay, we've got to stand up now and kind of go, okay, we see the issue. We've got to do something about it. You can't teach someone how to do an audit, listen to their issues, and then not help them make the change. So we proposed a few changes, and I think the top one really gives the key, is that we gave people principles. We didn't give them exact things to do in an exact moment. We empowered them to use their clinical judgment. So the first one was asking staff to risk assess themselves when they needed to wear gloves. And that was really important. It was not taking away from their intelligence, their clinical experience, each different moment that they would have to translate this into, but actually saying, this is the principle, you've got to go away and do it, you've got to go away and find out how to put this in practice. And we particularly wanted to focus on IV preparation and administration, because we found that that was the times that we were using gloves the most. So then we went away and kind of did the research. Is this backed? You know, we've seen it in practice, we know we need to make the change. What's the research actually say about this? So it came to light, it mirrored everything that we predicted from our audits. If you're wearing gloves to protect your patient, put sterile gloves on, okay? And a lot of staff have that myth that if they put non-sterile gloves on, they're protecting their patient, and they're not at all. Because we have boxes of non-sterile gloves on the walls, don't we? And they're just open for days, months, years, collecting spores, bacteria, everything else. Sometimes they drop on the floor, and the cleaner picks them up off the floor and puts them back in a box, don't they? And you think, oh, all the contamination that's going on there. So if you want to protect your patient, wear a pair of sterile gloves, yeah? So why on earth do we wear non-sterile gloves? Whether it be PVC or nitrile, why do we wear them? And it should be to protect ourselves. So what are we protecting ourselves from? Any harmful chemicals, bodily fluids, mucous membranes, anything that could harm me is why I'm wearing them. So just putting that instinct back into our teams across the hospital, the why. This is exactly what we found in our audits, and it's exactly what was in the research. And this isn't me, Wilson. It's another Wilson that is far more intelligent than me. And she found, along with another lady, that actually wearing non-sterile gloves increases that cross-contamination and the possibility of hospital-acquired infections. And you can picture that. You know, if I empty a catheter but keep my gloves on, and take that bottle out of the patient's room and take it into the dirty utility or somewhere, I'm just carrying that infection all the way through the ward, okay? So just really thinking about those moments that I wear gloves and actually taking them off when it's appropriate. Also, this research was in adults, it's not ours within pediatrics, but just actually if you're still wearing gloves, you're making your patient potentially feel dirty. And that's really not a place as a carer that you want your patients to be. So we proposed all of that to our various different teams, and really those are the key research kind of aspects that we took forward and shared. We did need to look at medications because we were obviously talking about IV preparation and administration. And so we again went for principles. We didn't say this particular drug on page this of the medical formulary, you do this. You know, we gave very broad principles. And we just said risk assess when you wear gloves. So if you're going to come in contact with a bodily fluid, wear gloves, yeah? If it's a nose drop, an eye drop, or rectal, put a pair of gloves on. If it's a therapeutically active cream, we said wear gloves. You know, if I'm moisturizing somebody, that's fine, that's okay. But if it's steroid cream, that's a whole different matter, and I don't want that absorbing into my own skin. Or if I was doing anything with liquid hormones or a cytotoxic medication. So we just simply had those broad principles. And then we needed to implement it. So our very first thing, we'd done the research, did that back up our audits, what was the picture that we were seeing? Next was the stakeholder meeting. And I'm so glad we did this, and I think I would repeat this for every project that I ever do now. We got in a room, everybody that we thought would tell us we were mad. Everybody that we thought would challenge us and say, well, you can't do that on my patients because they're special. So we got in the chemotherapy nurses, the dialysis nurses, the teams that put in your central lines, everybody that we thought would go, no. And actually, they pushed us to go further. So where we'd talked about general cares or administering drugs, they talked about doing central line dressing changes and everything else. So that was a really good challenge to kind of take us to the next level and know we had that backing and know that they'd quizzed us there. So when we took this out across the hospital, we'd already been quizzed by the people that would have the most questions. We then had other, I suppose, within their questions. If you normally make a change in somewhere like a hospital, you normally start with one ward, right? And everyone teaches you in quality improvement, start in one small area and then magnify it upwards to see how it goes. But at Great Ormond Street, we have patients that literally live with us, and they live with us for years, and they move from one ward to the next ward. So they might have a brain tumour taken out on one ward and then get their chemotherapy on the next ward. So you can't make a change on one ward and then have the parents say, well, who's giving the right care? Where's the difference? So we had to make this change across the hospital in one fell sweep on one day, which was no mean feat. So we took an approach that we take time and time again in the hospital that our teams are really used to. We spent a month doing a trainer-trainer. We got our ward managers, our educators, our infection control link nurses, and we spent a month training them just with some really simple PowerPoint slides with the principles on. This is what we want you to share with your teams. We also went and saw all the pockets of staff across the hospital that people don't think about. We went to see the school teachers, the occupational therapists, the porters. I mean, going to see the porters in the basement where no one's ever come and done a teaching session for porters is fairly significant to them and their team and how they then practice. So we spent that proper month investing that time. And then we gave everybody a month to relay and tell as many people as possible that they could in their areas. And that was really interesting because we then saw the effects of what worked and what didn't. So the areas that don't work is if you send an email with an attached PowerPoint, no one reads that. That's never going to happen and no change is ever going to, take place. And so we could spot those wards quite quickly. The areas where they did make a massive difference were things like they would go to each member of staff with the principals, talk them through, and then they would try and observe their practice and question them as they did their own practice or nudge them. So if they were reassessing how someone gives IVs, they would watch them and question that muscle memory as they go to pick up that pair of gloves as an automatic pilot. And that's where we saw it ingrained really quickly. And then we had a launch date, and we chose, there's a national kind of hand hygiene awareness day, and so we chose that day in May. And then we were like, okay, we've got to sustain this project, because the last thing you want to do is make a change, and then how do you do it? So for the first year at least, we did communications across the hospital every 3 months religiously. We would go to multiple meetings. We'd even have screensavers. And the key to that was we would always say, thank you. You have done this. So it was never about we have made this change. It was always about the staff that had done the change. And really, because it's not me that stopped using 21 tons of gloves because I physically couldn't do that. It was everybody else that implemented that change that made the difference. It was all of our staff that did that. So just really saying thank you to people and putting that positive tack on. I suppose there's another step beyond that I haven't put here, is how did we then go from that just being something that we communicated out every 3 months for the first year? It was embedding it into our normal practices. So it's now in our hospital induction. It's in all of our drugs administration assessments. It's in our when you've got a healthcare assistant, it's in your how do you bath a baby? Not with a pair of gloves on, because the gloves just get flooded, right? So we questioned it and we added it to all of our training, all of our policies, all of our guidance. I'm going to skip past that one. Oh, hang on, no, I'm not. So this was our very first year. It's not the best graph, but it sort of shows, this is the aspect before the change, and then here is the change. And you can start to see the decrease here as we go. But there is a better graph here. So here you can see where we implemented the change. If you follow the green line, that's our average. And then you see these spikes and all of the various things going on across. The very first spike here, we opened a new hospital building. So the procurement team therefore stock up, and it makes sense, doesn't it? They mass stock ready for you opening a new building. And then we hit COVID, and Great Ormond Street wasn't like every other hospital, because we only really take emergencies and elective surgeries. We don't have an A&E. So where everyone else got crazy busy, we were the opposite, and we were sending staff out to other hospitals to help them. And it meant that we weren't procuring as many gloves. But it also shows that actually the government took over how gloves and our PPE were procured. So we saw this massive variation in this period here. And then a lot of people say, well, what happened after COVID, And actually what we were really glad and what we really saw was another step change. And that's because our staff knew the theory and the principles in the first place. We didn't have to reteach them. They knew what made sense. And so they went back to it. Because nothing during this period had made any sense. Everyone was so hyper anxious, people were using more PPE than was ever necessary. Okay, and we'd all kind of moved to the use more PPE rather than far more hand hygiene, please. So seeing that extra step change. You can see here, and I've probably got them on the next slide as well. I'm going to highlight the little T-Rex. Okay, we're a children's hospital. If you make a change and make it visible in a format that makes sense to your group. Yeah, so we had a little T-Rex made out of gloves on every one of our slides that fed back because it meant something to someone. It's not like a London bus or how many taxis would this way. This is our first year. And really what I wanted to highlight is that I think any kind of sustainability change you make, you measure it in this triple bottom line, right? And so the environmental impact, and we've not worked this out in sort of how much CO2 equivalent would this be, but it was 21 tons of gloves that we saved that very first year, which was like 3.5 T-Rex or something, which is really crucial number. And the associated waste, obviously, that comes from that. Over £100,000 of saving. To the clinical team, that didn't mean so much, but when you talk to the exec team, that gets them on board with the change, right? But also crucially, I've put it here, one of our team took a photo of her hands at sort of 6 monthly intervals through the first year, like so beforehand at 6 months and a year. And you could just see that demonstrated that reduction of those red sore hands. And it was just incredible. We also saw this, it was feedback of parents actually just phoning to say thank you. And when they'd relayed this change to their special needs school and different places like that, that actually kids become very phobic very quickly. And it's hard to know what they're going to become phobic of. I wear blue in my everyday life, in my uniform. And so you walk into a cubicle with a 2-year-old and they scream at you because they've learnt to be afraid of the person coming in blue. And what we realised actually is a lot of our kids, it wasn't necessarily the uniform that's the trigger for the fear, it was the putting of gloves on, because that meant something nasty was going to happen. And so actually taking gloves out of the equation reduced the fear factor as well. So a really nice kind of triple bottom line that we were seeing there. if I go back to this, if we look right to present, it's like 12.3 T-Rex. So I think that's pretty good for a really small hospital in the equation of the hospitals that are out there. So if I was implementing this again or a similar type of project, what are the extra things that I would think about or sort of advise people to look at? What's your why? So for me, my why right at the beginning was I've got a responsibility not only for the patients that I care for, but I've now taught these staff how to do an audit, and I can't not teach them the change management that goes with it. So that was my why. Also, and I suppose what I would also then kind of jump to is what's the why of your stakeholders? Because not everyone in the room is going to think about sustainability the way we think about sustainability. So for instance, if I talk to Helen about things like this, and she's our infection control lead, she helped lead this project. Actually, the thing that triggers her more is that social equity of who were the people that had to make the gloves in the first place and what were their working environments. That would be her trigger. If I talk to the chief exec, those pounds would make a difference, right? So it's the learning what's the why to your stakeholders, because otherwise you're never going to get an engagement. And you've got to listen to them and understand them before you kind of push your own agenda. Then making sure you've got a baseline and what your baseline is. And I've noticed this when we get multiple phone calls or emails from other hospitals, how would you do this? And actually, we were really fortunate that we had these baselines in the first place. So we knew all of our infection rates, whether it was for a central line, whether it was for hospital-acquired infections. We knew our infection rates inside out, and every single thing was investigated. So we knew if there was a variation positively or negatively, we would know what that was. We also knew our procurement data. We knew our referrals to occupational health. We had literally gone out there and gone, how else could we measure this? You know, what are the different factors that we need to consider? And we also now knew that we had good hand hygiene audits, so we could tell if this was going the wrong way or not. And here, who can help you introduce a project? Time and time again, people come to me and say, oh, I'm the sustainability lead for this hospital, and I would like to do this. And it doesn't work. It doesn't work unless you have infection control along your side, or it doesn't work unless you have the team of teachers that teach out there clinically on the wards. Everywhere is a silo in a hospital, and every hospital is a silo of its own. So get out there and find as many people that can collaborate with you as possible. And then for the sustained bit, what systems do you have in place already that you can utilize for your change so that that really embeds and stays in your projects? Really quickly, 2 slides on another example where we use the similar themes. So this is an example that we did in the last 2 years with a lovely lady called Jacqueline Gordon, who's an occupational therapist in our hospital. And she wanted to look at period health. And we realised that the statistics out there are really quite shocking in the UK. So now over 1 million people in the UK can't afford to buy period products. We've only just won for a change in our law where come January, some of the extra products won't be taxed. So you can talk about equality with that one. We also know that when you have an operation, you're more likely to have a period. So for some of our young girls, their first operation might be a spinal surgery or neurosurgery, and they might get their first ever period in hospital surrounded by strangers. And they might be in a state where they can't care for themselves. And that's really quite soul-destroying. We realised we don't stock anything. Well, we didn't stock anything in the hospital, which was really quite shocking. And in any of our lifetimes, any person that has a period tends to use about 11,000 disposable products, and we all know where they end up in our oceans, right? And in landfills and stuff like that. And we know, it's not a surprise, everything's plastic. So Jacqueline was amazing, just with a few little nudges, and she has arranged that now our occupational therapy team will supply sustainable period products to our patients. And we now just supply them as period pants so that they can be washed, reused, and they're reused hundreds of times over sort of a 3-year period, course of time. And They're more financially viable for people. They're more environmentally friendly for people. We backed it up with information leaflets that covered the whole range of everything you could get out there so that people could make an informed decision. And we also added it onto our documentation checklist so that as you're admitted into the hospital from the age of 8, we will automatically ask you now about your periods, when you have them, have you ever had them before, and do you know who to ask if you need some help. So just a nice example there, and some really great feedback about people actually gaining their independence again that they wouldn't have had in hospital before that. So, yeah, references. Thank you.
About your work. And I have some questions, but maybe I will ask the audience because they have the priority. So maybe, yes? First question?
Thanks for a great presentation. In my experience, and this will be a question, don't worry. It's especially in the isolation wards that there is an issue for my healthcare colleagues who go in and they're extra careful, especially about gloves and single-use barriers. In that case, did you also touch upon that?
Oh, yeah. Yeah, actually, because there were 3 of us leading this project, and if I'm very honest, when we launched it, our senior management team went, oh, go on, go for it. But I don't think they really necessarily were aware that we were also really panicking, that what happens if we've got this wrong? What happens if we see a spike of infections and everything else? And so what we decided to do, our first change, we changed all of those aspects, but without looking at our children that were in isolation as a protective isolation or our children that were in infectious precautions. And we made that second step change sort of the September later because we were so nervous. And actually, our head of microbiology at the time said that he regretted not giving us more backing because he wished we'd done it and was trying to push us to do both changes at the same time. But it goes back to those principles and that research, because people are, you're right, when someone's in protective isolation, they want to put on more PPE. But just remembering that that PPE, if it's a non-sterile glove, could be more contaminated than your hands. So just keep reminding people, actually, if I wash my hands, and that's where I need my paranoia, it's not putting on the PPE, it's decontaminating my hands. That's where I need to think. So that's where we went with that.
Yes, another question from others?
Yes. How do you keep the level over time? Like we had kind of a similar project in one of the hospitals and it was kind of successful, but now just it's starting.
Maybe, wait, can I give you the mic quickly? Or I think that's like, sorry, because maybe somebody... Wait, maybe you can keep it away.
Okay. Just to keep the level. I asked how you keep the level in the next 5 years or something, because in our hospital we can see it's increasing again, especially the whole society is using gloves. Everywhere we buy a salad, they use gloves, and people think, okay, they use gloves, it's nice, it's clean. So, I don't know, do you have any recipes for that?
Yeah, and I think that's about ingraining it into your normal systems, because actually what we've done over a 5-year period isn't just sustain that level, we've gone down again. And I think we've ingrained it into every aspect of our teaching, of our training, and it's in all of our policies and stuff. But also we do keep reminding people, so we had a 5-year celebration of, guys, you did this. Wow. Like, thank you so much. Do you know that that's now 12.3 T-Rex? Like, and just keep that messaging going of thank you, you've done this. And that really, really helps, yeah.
Okay.
It's now their practice. It's not something that, it's something that when you're new to the trust, people question, but our staff have such few principles to follow. It's not complex, there's just a few principles to follow that they all feel really happy ingraining that. Because we had the question when we first started the project of, we asked our communications team, do we need to put posters up for all the parents? And do we need to translate them into all of the different languages that we see in the hospital? And, every different kind of Arabic version of, everything. And they said, no, don't highlight that this change is happening. Don't put this up on posters. Don't make people question your care. But make sure the staff know your principles so that if they are questioned, they can answer it. And so that's why we kept it so simple. Yeah.
Oh, that's good. Thank you.
Thank you. Yes, I was also wondering, I can use my moderator power, how you deal with always all the staff changings that are happening, because I've heard from other hospitals when they're trying to implement some sustainability measures and bring awareness to the staff, they're dealing with people just coming and going all the time and having to inform the people all the time. Like, how do you deal with that?
Yeah, that's a really fair question. And actually, at Great Ormond Street, because we're so specialised and we're London-based, like, firstly, if you're a nurse, you can barely afford to live in London. So people will go there and they'll live in London for maybe a year or two, and then they can't live in nurses' accommodation anymore and they have to move out, right? And they move out of London. So our age group and our group of staff stay very short periods of time. They come for the specialised training and then they leave. And that's a sad reality for us, but possibly a good reality for the wider healthcare system, because we've trained them as much as we can and then they move on. So yeah, we do have that constant turnover, but I would probably say the same. We've ingrained it into every one of our systems, and it's just a few really key principles. And so that just relays time and time again. Yeah.
Well, that's a great way of putting it, that people are just, yes?
What about the climb? What about the regulation, medical law? Because we are regarding to medical law, don't worry about the patient with infection. Maybe it's an example. And if any infection at hospital, as not the patient regarding to that nurse don't use gloves.
Yeah, I mean, we've not had infections in the hospital since. We're not suddenly a miraculous hospital, but all of our infections are, our hospital-acquired infections are investigated, and our team go out there and find out what it is. I mean, our team are so rigorous that they'll go and they'll swab where the tea and the coffee is kept in the patient's kitchen and things like that. So they investigate where every infection's come from, and so far we've not found anything linked to our change of glove use, definitely. We've obviously had other reasons that we then resolve, but nothing linked to glove use. And what we hope is the fact that we didn't see, and I suppose like someone talked about earlier in one of their projects, we didn't see an increase. We didn't see a decrease either, really. We just saw a static level. But we know that every infection, certainly that was significant, has been investigated. Yeah. Yeah. But well, now it's 5. Yeah.